food resources, where there might be parks or open space, even where the national diabetes programs are and any of the other programs. And so I think this year we're planning to try to help a lot of agencies actually learn to use this website and actually try to scale this. The Wellness Center, who is Janina here? Janina, you want to say a word about this? This is a very innovative. Janina is the medical director of the Wellness Center at OIC USC.
So I'm a primary care physician working for the county, and I also work as the medical director of the Wellness Center. Basically, it's an amazing sort of experiment in how to link patients at a safety net medical center to community-based resources for a variety of things. As a primary care internist, I use it a lot for lifestyle modification. So anytime I identify someone who has diabetes or hypertension and does not seem to be meeting the goals that I want them to, and I think lifestyle is involved, I'm basically able to just stop. I don't try to figure out what they're eating. I don't try to make culturally appropriate suggestions based on my limited knowledge of whatever the thousands of different cultures our Angelinos are coming from. I'm able to link them to community-based programs where they can get ongoing lifestyle modification support, including evidence-based programs for diabetes prevention or diabetes management or chronic disease management. And so basically the Wellness Center is one model where you actually bring community-based organizations and you give them office space on a hospital campus. So we now have around 20 community-based organizations that are right there on the hospital campus, and we're working on linking the patients of the medical center. We're open to everybody, so my patients will often come with their families. So say, dad has had a heart attack and his blood pressure's out of control. Well, his wife is gonna come with him because she's the one who's cooking. So they can both come to the evidence-based programs. It's not dependent on insurance status, and thank you. We are about to turn 5 at the Wellness Center, and we're about actually to get our first big look at our outcome data. We're able to link up with the county data to show impact on health outcomes, on healthcare utilization, and really show sort of what we are contributing to the population health around where we are. We're in Boyle Heights, but also to all the patients in the county that we see.
Yeah, and I think, Janina, the other thing is that the organizations that is at the Wellness Center really is sort of set up to really take care of the whole person, because it's not just the health navigators that do the evidence-based programs. They also have people who actually help uninsured patients get health insurance, and then of course there's many services that are very popular, like legal aid. And I would say that's actually one of the most popular.
And I would say also, as a primary care doctor who refers to this center, I am always thinking I'm sending people there for lifestyle modification. I'll check diabetes, I'll check hypertension, and then they get there, and because of the community-based nature of the place, they're finally able to disclose, say, housing instability, domestic violence, like all of these really big barriers to health. That can then be addressed by other community-based organizations that we have there.
Great. And I think you're available to come back and talk some more.
Yeah. Oh my God, I can go on for so long.
Yeah. So again, along the line of sort of building out these clinical linkages and providing technical assistance, one of the projects we actually did with Ultimate was to actually come up with a toolkit on how to kind of implement and design comprehensive medication management. And we've actually distributed this. I don't know if things are actually being implemented, but we certainly have provided these toolkits to the community clinics across LA County. And finally, I just want to, all this said and done, just want to leave you with, this is actually an action framework that our Director of Public Health, Dr. Jonathan Fielding, had once talked about, which is that from a public health, population health standpoint, I think we recognize how important it is to make sure that our clinical system works, our health system works. But we also recognize that what's around that system, that in many ways is the primary role of public health. Trying to make sure those other environmental factors, agencies, and connectivity are actually in place and is done well. And I think if we could do that, not only help the patient in terms of health care, but I think it could also drive down healthcare costs. So anyway, hopefully, I think my main goal is that as long as I can convince you that I'm not a restaurant inspector, public health actually could do so much more, and is planning to do to move forward with some of this. I think we really value what we're doing here with RightCare initiative, and Dr. Fremont, as I mentioned, we're definitely going to take advantage of your wonderful paper from Health Affairs, and I hope we could replicate some of that here. So, thank you.
That was great. I didn't realize all of the things that you do. It's a really multifaceted approach to this never-ending issue of healthcare. You did mention the the school sites for exercising and whatnot. Since behavior change is really challenging, since behavior modification is really challenging, especially as we get set in our ways as we get older, I'm wondering if you have other opportunities or programs in the school to maybe start sort of re-educating at a young age, that maybe students can take that information back to families and initiate some change that way?
That's a great question. Yeah, yes, we do. I think I didn't talk about our division of chronic disease actually also handles the SNAP Ed, the food, the supplemental nutrition assistant program education, and some of the efforts there. What we've been trying to do is kind of like hit at different parts of the school system. So one is trying to get them to have a more robust school wellness program, which again sounds easier than it actually is. Other pieces, for example, we've actually supported the development of community gardens at schools, and the idea, it's not so much just so they have something to do. The idea is that if we could introduce children early to the growing plant-based food, they tend to kind of adapt to it and they'll take it throughout their life course. And so we're really trying to do that too. And then, of course, in physical education, we are trying to get schools to actually adhere to the. I think it's not so much there isn't standards. Sometimes they're just not being done, and so we're also working on that.
More questions for Dr. Quell?
Thank you.
I'd like to introduce our next speaker, Shawni Smith, who is the Regional Director of Quality Systems Improvement for the American Heart Association, which I think all of us at least know of the American Heart Association. And Shawni, it looks like you've had quite an experience here in the healthcare industry, which is really helpful for cardiac disease, and particularly a Medicaid background, which is, again, for the state of California, quite important as well. So I'd like to introduce you to give your heart failure quality improvement speech and have some good questions on that as well.
Thanks. And thank you to the Heart Failure Work Group for bringing Shawni to us.
Hi everyone, and thanks so much for having me today. I also wanted to introduce my colleague Bliss Rayo Toronto, who's sitting over there too. Her and I are both regional directors for the American Heart Association, and in our role, we have the privilege of working with hospitals and EMS agencies to ensure that stroke, AMI, heart failure patients get to the hospital that's best equipped to handle their condition, and that while at the hospital, they receive treatment according to the evidence-based guidelines in a timely manner. So we'll talk a little bit more about what we do in LA at the American Heart Association, but first wanted to go into the readmission reduction programs and the penalties that are being assessed nationwide, but do a drill down on LA County and Orange County. No disclosures. So I put a slide in here about the prevalence of heart failure, although looking back, I don't think that this probably needs repeating to this group about what an important healthcare issue heart failure is. Over 5.7 million Americans are currently living with heart failure, and that number continues to increase. It's also a leading cause of healthcare expenditures in the country, which I'm sure everyone in this room is well made aware of. So talking a little bit about readmission rates, approximately 1 in 5 Medicare patients usually have a 30-day readmission rate, although with various quality improvement initiatives and the readmission reduction program, which we'll talk about, it is improving, although I think it's safe to say we still have a long way to go to improve this statistic. So why are 30-day readmission rates happening? There's a lot of breakdowns that could happen in the process, whether it be from patient assessment, perhaps not including the right people in that conversation when the patient's first assessed, getting adequate medical history, medication list. Family or caregiver education. Are we asking the families and caregivers to teach back what we think we're teaching them so well? And are they able to take that education forward as they continue to take care of their family member with heart failure? The handoff communication between physicians, always a challenge. And following discharge from hospital, a lot of breakdowns can happen, whether it be from following through with the follow-up appointments, obtaining medications. I just had a good conversation yesterday about the challenges associated with getting the medications, even if they may have been prescribed to discharge. So there's a lot of breakdowns that could happen that may contribute to the 30-day readmission rates. So in 2012, as a result of the Affordable Care Act, the Centers for Medicare and Medicaid Services implemented the Hospital Readmission Reduction Program, where hospitals would be penalized financially if they had excess readmission rates, looking at the 30-day window. The expected rate is based on the average readmission rate, or what you would expect the hospital readmission rate to be for each specific hospital based on a variety of characteristics. And I will kind of caveat this by saying that CMS continues to refine how that's calculated each year. They issue a proposed rule for public comment if anyone is interested in commenting on that, and then subsequently publish a final rule. So the readmission rate and how that's calculated for this program is subject to change every year. So we basically will compare the actual readmission rate to the expected readmission rate, and if it's higher than expected, that's when the hospitals will be penalized financially. So for fiscal year 2018, which would be October of last year through the end of this month, 2,500 hospitals across the country were penalized for excess readmissions, which is quite a lot. For fiscal year 2018, hospitals could be penalized for up to 3% of their Medicare fee-for-service claims. So in other words, it's really a ding on their reimbursement, and it's definitely clear financial implications for the hospital, and a priority, and it should be a priority for them. Did want to note, in case anyone's unaware of this, that information about what I'm about to present to you on this is all publicly available via CMS's website. You can go to Hospital Compare It will actually list hospitals by name and what their penalties were. You can go back, 6 years since the beginning of the program if you're interested in a specific hospital. So I was asked to pull together, using the publicly available data, the readmission reduction penalty implication for the 2 surrounding counties. And here's where we came up with. So in LA and Orange County, you can see I looked at 73 hospitals and 21 hospitals. The average number of years the hospital had been penalized in the last 6 years was pretty close, 4.7 for LA County and 4.6 in Orange County. The number of hospitals and the percentage of hospitals penalized for fiscal year 2018 also really high. So 79.5% of hospitals in LA County received a penalty through this readmission reduction program, and 81% received a penalty in Orange County. I wanted to see if the trends were getting better now that this program had been in place for quite some time. So there wasn't a clear trend when looking from in the past 6 years, but kind of drilling down just to the past 2 years, between 2017 and 2018, I was actually pleasantly surprised in LA that 68.5% of hospitals either improved what their penalty was, or if they had no penalty in 2017, they continued to have no penalty in 2018. That statistic was slightly lower in Orange County at 61.9, but I was surprised to see that. The median penalty, so this is the percent reduction of their reimbursement that they would receive. And again, the cap was 3% in fiscal year 2018. The median in LA County was 0.36%, and in Orange County was 0.1%. And the max, so this was the hospital that received the highest penalty in LA County was about 2%, and in Orange County was much lower, 0.69%. So this means, just to kind of put it into perspective, so in LA County, one hospital received a 2% reduction to their overall Medicare fee-for-service reimbursement rate. My
So in
goodness.
other words, across all of their fee-for-service revenues,
Mhm.
they were reduced by 2% just because of the readmissions.
And Shawni, is that for the next year? Or is that looking forward their next year's?
Right.
Oh, yeah.
And the fiscal year 2019 rates, they should be coming out if they're not already. They're effective this October, so that might be a topic of conversation once those are released to see what those trends look like.
And that readmission penalty is based on all those diagnoses you showed, not just CHF?
Correct. Yeah, good question. Mhm.
Those are all size hospitals, right?
Yes.
Okay.
Can
Shawni?
you repeat that question?
And I actually have,
There must be different sized hospitals. I was
No,
wondering.
your question was loud, I couldn't hear your question.
yeah, and I think you bring up a point I want to make is that, to quantify this in terms of the dollar amount and the dollar impact that this would mean for the county, I wasn't able to do because it really depends on the size of the hospital and how many Medicare patients they're seeing to what impact this would mean longer term. For some hospitals, this might be a huge hit, and for others, it might not be that much if they don't see that many Medicare patients.
If you couldn't break it down by individual hospital, could you give us an idea of what it was for Los Angeles County versus Orange County?
I don't
To
have
quantify that?
information. I don't know if anyone else in this room has studied that. I don't believe that is publicly available, at least that I found while I was doing this project. But it would be very interesting to find out what that number is.
May I just ask,
Sure.
Dr. Quo, do you have any staff that could try to get a beat on that?
Maybe. You're putting me on the spot.
Oh, well, just
What a
maybe
surprise.
explore it.
Yeah, we can explore it.
Any other questions? Okay, and then finally I looked at the number of hospitals penalized for 6 years in a row, so since 2012 that they've received, or the past 6 years, and it's 57% pretty much for both counties, so I think there's room for improvement there. So how can we help, and where does the American Heart Association, where do we in this room all fit into this? Well, the American Heart Association identified Los Angeles County as a concept market or a target area in looking at all of the counties in the nation. So New York was identified in LA, and I think as Dr. Poe mentioned earlier, if it can happen in LA and we're successful in LA, it's going to be successful in the rest of the state. And I believe that it can actually be successful in other parts of the country too. So AHA is really focused on what's happening here in Los Angeles County, which is part of the reason why Bliss and I have the position that we do to really work hand in hand with providers, groups like this, payers, to see what innovative approaches can we take to really move the needle in heart failure, and then also the other areas of care that we work with. So I want to talk a little bit about our Get With The Guidelines program. By show of hands, has anyone heard of this or has familiarity with this before? Okay, great. So for those of you that don't, it's a quality improvement programs, and we have 5 different focus areas, heart failure being one of them. We also have different modules for stroke, AFib, AMI, in-hospital resuscitation, etc. So just going to talk a little bit about our heart failure program. So this was launched in 2005, and the focus is improving care and ensuring adherence to the latest evidence-based guidelines that AHA is publishing. Over 1,200 hospitals currently participate in our Get With The Guidelines heart failure program, although in LA, I think we still have a lot more hospitals to get on board. In LA, I believe we have 20 hospitals participating, and in Orange County, I believe there's 10 hospitals participating. So that's one of the goals that Bliss and I want to work with you and work with others in our community, is getting more hospitals on board with the Get With The Guidelines program. So participation in Get With The Guidelines is at the hospital level. Hospitals have access to a patient management tool, which is an online software tool that was developed by clinicians for clinicians. So captures key information on heart failure patients that can then be used internally at the hospitals to drive quality improvement initiatives. Hospitals that participate in our Get With The Guidelines programs also have one-on-one support from either Bliss or myself here in LA County. We also have counterparts across the country that work alongside the hospital to review the data, identify what the gaps are, and then brainstorm what best practices could be, knowing what other hospitals are doing and what's been successful. There's also real-time benchmarking. So as you're everyone's putting in data into this patient management tool, you can see how you compare to other hospitals within your state, within your region, etc. I will say that the program there is a small fee for the patient management tool. It's usually less than $3,000 a year, but we oftentimes do an ROI for hospitals based on the penalties that they're receiving for the readmission reduction program, and they see a cost savings. Go ahead.
Does the patient management tool link up with the electronic health record?
It can, yeah. We have, if you have Epic, we have an Epic. It's not a complete interface, but it works well with that. And then there's also an upload feature where hospitals have worked with their IT department to just automatically extract data from the patient medical record and upload it. Is there another question?
Well, no, I wanted to pause because we were thinking about cost. Everyone always does. And hospitals are going to wonder what is the cost of this program without really recognizing the savings side. You did mention that, but I want to go back and tag that with your previous slide that talked about the percent of hit that the hospitals are getting. And this is just one program, because the readmission program and the hit that they receive covers many, but this is one way to reduce that and actually will pay for not only itself but others.
Absolutely, absolutely. And on the plus side, these hospitals, there's a lot of great things happening in this county with heart failure. And once hospitals that participate in this program receive or achieve certain performance levels, they are will receive an award and will be published in the U.S. News and World Report, so they'll get some publicity for the great work that they're doing. And actually, Bliss came from a hospital that was using Get With The Guidelines. We recruited her because she was so good at implementing Get With The Guidelines, and now she's here and able to provide one-on-one consultation with hospitals. So I don't know, Bliss, do you want to say a few words about your experience in working with this program and what you observed?
Certainly. Would you mind going to the podium so we can
not
hear
at all.
you better?
And
So Bliss, what hospital were you with?
I was at a hospital not in LA County, but not very far away either. I could give you a county. I live in Ventura County.
Oh.
I was gonna say, did it have a color?
So, just to give you some background on me and why, what meshes me well with American Heart and why that meshes well with working with the community for cardiovascular care. I have been a nurse for about 20 years, and most of that nursing, actually all of it, was in some kind of cardiac space, starting from telemetry to the cath lab, and then being a manager over clinical operations in cardiology department, and then as my facilities programs grew, I moved into program management. And included in the program management was I oversaw the heart failure program. We did, in my last facility, use Get With The Guidelines. It was enormously helpful in terms of, in real time, tracking your performance and tracking patient outcomes. So when your abstractor abstracts your data, puts that data into the PMT, into the patient management tool, we were then able to run reports on specific things that we wanted to work on. So for instance, one of the challenges for heart failure patients are readmissions. Why are they coming back? So we can, using the tool, you can look at certain measures that we at the American Heart have created based on science, showing us that working on these interventions will show better outcomes for your patients. So we were able to see where our gaps were, make changes in our practice, and then really making that patient care more holistic by adding some features to our program that reach the patient after discharge. So that was one example. There were other things like medication management, making sure the patients are on the correct medications, evidence-based beta blockers, ACE inhibitors, making sure that our providers were ordering the correct medications and not just the same old low pressor twice a day. We wanted them to, really focus on using evidence-based beta blockers like carvedilol, and also then we had nursing staff that worked with these patients, as I said, even after the hospital, making calls, following on the outside, doing a lot of assistance on the outside, bridging that gap between follow-up on the outside and hospitalization on the inside, with the hope that our readmission rates were going to go down. So that's just an example. This is part of why I joined AHA, because I really believed in that program. It is, and this is going to sound so corny, but that was where my heart lay for all my cardiac programs. Because when you're in healthcare, what you want to do the most is reach patients, right? So I felt that this program really made an impact on the actual patient and their outcome in more ways than just a number. We implemented changes that reach the actual patient. So does anybody have any questions? Let's see.
Were you able to quantify the impact? So once you put in Get With The Guidelines, were you able to demonstrate an impact on quality or cost?
Yes, but that wasn't immediate. That, to track that kind of data took time. What we could see using Get With The Guidelines was, if you have your data input monthly, you could track almost real time your performance with that particular measure. But to track financially was that is a much later, you know, that is something that we forecasted in the future as a goal.
Thank you.
You're welcome.
Shawni, you mentioned some of the barriers and issues